at a previous meeting about changing the format slightly today. So what we'd like to do is record the presentation start of the session, so the first half of the session, and be able to share that along with the presentation, so we can share that with other people. But what we won't share is the questions and discussions from people, so that feels safe, that people can ask and kind of share identifying information. So we're trying it. Please give us feedback whether that works or doesn't work. But we've just been trying to kind of test and make it work for people to have a safe environment, as well as learn and share the information. So today is open to anybody across West Yorkshire who wants to join. We have topics monthly where they are around neurodivergence. Today is going to be epilepsy and neurodivergence. And we ask for people to if you want to ask questions when the time is right, please use your hand to do so. Please stay on mute throughout the presentation. Feel free to keep your camera on or off, and also use the chat function as well. This is an informal meeting to share good practice, to share learning, and please try and be mindful around the language that we use. So we tend to quite easily go into our acronyms and our kind of speech, which we know happens. So please, if you don't understand something, do ask or pop it in the chat, and try to be mindful of that when we're doing so. Also try to be mindful when you're sharing information. If that is personal information, do that in a safe way and that you feel okay sharing that. And anything else? I'm looking at Rhiannon and say anything else before I hand over?
No, I think you've nailed it.
Okay, so we will start the session. So I'm going to hand over to Casey and Fraser to introduce themselves and introduce the session. Are you okay sharing your own slides? Yep, brilliant. Okay, so I will shut up and hand over to yourselves. Thanks.
Lovely. I'll go first, Fraser, and then I'll hand over to you, because I know you're going to do the majority. But thanks for allowing us to come today. My name's Casey Russell. I'm a project manager at the West Yorkshire Children, Young People and Families programme, and I work on long-term conditions, so that's asthma, diabetes and epilepsy, and we have a West Yorkshire like professionals meeting that we meet every other month to work on some of the service improvements and to make things better, really, for children, young people and families who experience epilepsy and live with epilepsy. So that might be improving diagnosis, or improving the care that they get once they come into hospital, maybe how quick they get diagnosed or tested. But also we try and think outside the box a little bit more as well about how maybe their care is within schools, or what the medication is. So really just all round, we want to make things better for children, young people and families. Fraser's presenting today, so I'll hand over, but I just wanted to say hello, and I will pop my email in the chat in case anybody wants to contact me afterwards. If you have kind of comments or ideas about the work that we do at West Yorkshire, we'd really love to hear from you. But over to you, Fraser.
Thanks, Casey. So yes, good morning, everyone. I'm Fraser Scott, paediatric consultant, employed by Mid Yorkshire Trust and based mainly at Pinderfields. And I work with Casey. I'm the clinical lead for the West Yorkshire Epilepsy Group. So I'll share my screen and we can get started. So hopefully you can see that. Yes.
On mine, it's a little bit small. I don't know if you're on other people's. Is it about half the size?
Yes, I'm just about to start the. Right now, actually, you're seeing the slide notes instead.
Yeah, it's kind of doing the double. Yeah.
That's all right. I'll swap. Right now, hopefully you should see the screen.
Yeah, thank you.
Right, excellent. So all that means is I can't see any of you now. So I'm going to whiz through this, and there'll be time at the end for questions. But if I say anything that's particularly wrong or controversial, then just shout out. So yes, as Casey says, thanks for the invitation this morning. We kind of did jump on it with both feet because we are always trying to sort of connect silos and sort of bridge the gap for children with epilepsy, particularly when they have other associated problems. So this seemed like a good opportunity. And it's also serendipitous because I was starting to think about this issue, and particularly how it applies to new patients who may present with vacant episodes. And so this kind of was the spur to get me to do some reading. So I've actually learned quite a lot in the preparation of this talk, which is, of course, a good thing. So the plan for the next sort of 20-25 minutes is just to introduce this concept of bidirectionality, a little bit about EEGs and the part that they play in the diagnosis of epilepsy, some specific facts and figures around epilepsy when it co-occurs in people who are on the autistic spectrum or who have ADHD, a little bit about vacant spells and how the patient and family and the clinician figure out what's actually going on. And I'm hopeful that a lot of the information that I found out is going to lead to a clinical guideline that we're going to trial first in mid-Yorks and then perhaps further afield. And then there'll be time at the end for questions, a few sort of concluding remarks, and then I've got slides at the end, which are the references that I've used, and I'm happy to share this talk. One of the first things that struck me was how huge this topic is. So this what I'm going to be talking about today can only hope to scrape the surface and give you a few of the headlines, but there's a lot more detail behind all of these issues. However, we'll dive in. So the first is just to sort of introduce this idea of bidirectionality, which is not always easy to say. This kind of idea that two separate issues are connected. So if you have epilepsy, you are more likely to have either autism or ADHD and vice versa. And it's not just the fact that the two go together, the two feed off each other. So if you have one, it's not just that you're more likely to have the other, but there can be an effect on the other so that it's more profound or affects the patient. So it's a reciprocal relationship. And so it's there between epilepsy and either autism or ADHD. It's also there between epilepsy and learning difficulties or cognitive problems. And of course, that also then feeds into autism and ADHD. And I think the feeling at the moment is that there's probably a common cause for this, which is probably genetic. The pictures on the right are just showing some of the other factors that also massively affect and impact on both the epilepsy and the other issues. So sort of bottom right, you've got sort of cheeky child. So this is just kind of representing behavior problems. Obviously, you've got medication and the effect that they can have on behavior, on cognition, certainly on impulsivity and other issues to do with ADHD. Sleep is a massive one. And again, is influenced and is kind of thrown into this complex relationship. And then lastly, deprivation and pollution. So there's a clear link between deprivation and not just incidence of epilepsy, but how problematic it can be. And there's some research coming out now to show that part of that is perhaps linked to pollution and climate change. So this is just a reminder that some of you probably know about this core 20+5, this NHS initiative for both children and adults to try and target and improve patients who are more likely to have healthcare inequalities. And so for the children's version of this, epilepsy was one of the key areas. And you can see the little sort of summary cartoon there. So it talks about increasing access to specialist nurses and ensuring access in the first year of care, particularly for those with learning disability or autism. And this idea of this bidirectional association or reciprocal relationship is there in adults as well. And the kind of most evidence in adults is around the link between epilepsy and mental health problems, particularly depression, as this sort of summary of this paper shows. And you can see the sort of graphs are probably quite small to read, but you can see the definite reciprocal relationship between the sort of depression and epilepsy. These are just some snapshots taken from the CHESS and the SCENE study. So these were two studies coordinated, I think, by Young Epilepsy. So the CHESS one on the right was looking at, in school-age children with epilepsy, the incidence of behaviour and learning problems. The one on the left was looking more at sort of neurobehaviour type issues. So they're both very good reports. They give quite sort of clear insight into the amount and the degree of difficulty that children with epilepsy suffer, and the effect that that has on their schooling, on their sort of social life and sort of family. So they're both easy to find on the internet, and I've included the references down below at the end of the talk. Okay, so that was just kind of briefly setting the scene. The next step is just to talk very briefly about the EEG. So this is Hans Berger, who was a German, originally trained as a mathematician and then studied medicine and eventually became a psychiatrist. So he was the first to make a recording from a human subject 100 years ago, actually this year, so 1924. So it was a 17-year-old actually who was having a neurosurgical operation, and so he took the opportunity and recorded brainwaves. He had some doubts about his own study, and it took him 5 years to publish it, and it took then another 9 years before it became established and recognized. So it wasn't until really the outbreak of the Second World War before the EEG was starting to be seen as a test that could be helpful and applied to patients with epilepsy. Although interestingly, Hans Berger didn't actually use it to look for epilepsy. He wasn't interested in that at all. Unfortunately, he committed suicide in 1941. Anyway, so the EEG that we had from 100 years ago is still the main test that is used today in patients who we think are having epileptic seizures, but there is a problem. It's not a reliable test. So half the time, it will be abnormal in patients with epilepsy. So the rest of the time, the other 50%, your test will come back normal. It also can be abnormal in patients who don't have epilepsy. So the quoted figures are anything from 2 to 5%. So as tests go, it's a bit rubbish. You know, it's not very good at ruling it in. It's not very good at excluding it. It is a test that's often done for children and young people who present with vacant episodes. And as you see from the later slides, a lot of those vacant episodes are not epileptic in the first place. And so a lot of the time it doesn't show anything, but of course you run the risk that it might pick up something which you could then misinterpret, and then it leads you off down the wrong path. It's not a particularly bad test as tests go. It's not, you know, it's not painful, but it does require lots of little sticky electrodes to be applied to your head. So that requires a stranger invading your space and putting all these electrodes on. And then you have to sit still for a minimum of 20 minutes, which for some children, young people, and some adults actually can be quite challenging. In patients with autism, there's a much greater chance that the EEG will pick up abnormal activity. But that doesn't necessarily mean that that proves they have epilepsy. So the average, as you see here, is 33% of patients on the autistic spectrum had an abnormality on their EEG, but were not having clinical seizures. And that figure, like I say, is an average. There was a review paper that I found which had 13 different papers in it, and the range was anything from 8% up to 80%. So it's very common to find abnormalities on the EEG in someone with autism, but that doesn't necessarily prove that they have epilepsy. And there's a whole variety of different things that can be found, but the most common are what's called centrotemporal spikes, and I'll show you what that looks like in a second, or occipital spikes. Spiky excessive activity either in the sort of center, middle part of the brain or towards the back. So just a couple of quick EEGs so you know the kind of things that we're looking at and talking about. So this is an EEG in a patient with what's called childhood absence epilepsy. So on the left-hand part, you've got a normal background recording, and then you can see the person has an attack. So you can see this change in the brain waves. It's throughout all of the brain waves, although you could argue it's maybe slightly asymmetrical, so it's maybe bigger and more prominent on some of the leads than others, but it's throughout the whole of the brain for a short period of time, and then they rapidly go back to normal. This is juvenile absence epilepsy, so a similar epilepsy syndrome, but in teenagers rather than younger children. And again, normal background, sudden onset, generalized, very regular spike wave activity for, you can see, a longer period compared to the childhood version, and then rapidly back to normal. This is a patient who's having focal activity. So just to kind of orientate you, down the left here, you've got letters and numbers, so they refer to the electrodes. So the letters are where the location is. So you've got prefrontal, frontal, central, parietal, occipital. So it's referring to the bit of the brain. And then the numbers refer to the sides. So even numbers are the right-hand side of your brain. Odd numbers are on the left-hand side of your brain. And then you should always have an ECG recording, so heart tracing, running along the bottom as well. So you can see it kind of stands out fairly clearly that you've got a normal background, but you've got this spiky activity, which you can see is mainly on the right-hand side in this sort of frontocentral region here and frontotemporal. So this is the kind of thing that you can see in a normal child, in inverted commas, who has never had a fit in their life. So this is an example of how you might be led astray by the EEG report if you don't interpret it with caution. Okay, so quickly just moving on to epilepsy and autism specifically. So I don't need to tell this audience of the prevalence of autism, which I think most studies suggest is between 1% and 2%. There is this male excess, although I don't know whether that's still as robust as it used to be. I think there's growing recognition of how girls present differently when they're on the spectrum, and how often they can learn to mask what would typically be the sort of obvious autistic symptoms. So I don't know whether that male to female ratio is still as pronounced as it was. It is well known that there is a clear link and increased risk of developing epilepsy if you have autism. And it's also, as I say, linked to learning difficulties. So if you have no learning difficulties, the prevalence of epilepsy is 8%. The prevalence normally of epilepsy in the UK is around 1%. If you have learning difficulties with autism, the chance of getting epilepsy is between 20 and 40%, so it's significantly higher. If the epilepsy is going to develop after you've already been diagnosed with autism, when and how does it present? So there's two peaks, so young children, so preschool, or adolescents or young adults. There is still that slight male increased ratio, but you can see it's not as pronounced as the sort of general male predominance in autism generally. So that's just an interesting thing to note, that girls are overrepresented in developing epilepsy. Just about any seizure can happen, but the common ones are what's called an atypical absence and focal seizures, so seizures arising from a particular part of the brain, and the most common is from your temporal lobe, and so they can be recognized by the type of symptoms and the sort of progression of symptoms that the patient experiences. So there is this kind of quandary for the patient and the clinician, that you know that the chance of the person developing epilepsy is higher, but you also know that the test that you need to diagnose it is less likely to be helpful because it may find an abnormality, but that might not be relevant. So how do you kind of figure all this out? So the main things that you need are actually going back to basics. So getting a good history of the attacks, for the family and the school to keep a diary for a week or two to see is there any pattern or trigger to when the attacks are happening. And what's really important is trying to get some video footage so that you can see what the person looks like during an attack. And then obviously from the patient's point of view, you have to get in to see the right person. So that's a kind of pediatrician with expertise in epilepsy. So this is just highlighting how important smartphones have become in the diagnosis of epilepsy. So it's been recognized from the 80s when people could start to afford camcorders that video footage of a person's seizures could be helpful. On the right here is a screenshot from the sign guideline on epilepsy, which again just highlights how actually sometimes video can be more helpful to clarify the diagnosis rather than an EEG. And on the left is a fairly recent publication, again, just looking at how helpful video footage is, not just at confirming whether someone has epilepsy and which type, but also in ruling it out and confirming that they don't have epilepsy. It's for that reason that in West Yorkshire we applied and were given funding to fund a trial of this company called vCreate, which allows patients and their families to securely upload video footage of their seizures to a secure cloud for then their clinical team to log on and look at the clip and can then message the family back to say what they think of it. So that can be helpful at clarifying diagnosis, optimizing investigations, and as obviously tries to make things leaner and more efficient. On the left is a business card that we're about to start trialing in mid-York. So when patients first come to A&E with a first possible seizure and they're being discharged home to get an onward referral into the first fit clinic, they'll be given this business card that has the contact details of the relevant team on one side and then a couple of QR codes. So one links you to vCreate so you can know a bit more about it. And then the other is just a link to the first seizure leaflet provided by the Pediatric College. So again, it's just an attempt to reduce paper and the impact on the climate. The other thing which is relevant, particularly for this combination of epilepsy and autism, is that there may be a unifying underlying diagnosis, which might be metabolic, it might be structural, it might be genetic, and that will impact on perhaps the type of seizures that the person has, as well as how they respond to treatment. So certainly genetic conditions are important to kind of think about. Autism is more likely in some of these more severe epilepsy syndromes. So you might have heard of some of these. So West syndrome, which was named after the guy who first described it in his son. Dravet, which is named after a French neurologist who described the condition, Lennox-Gastaut and others. So this, again, is kind of too small to read, and bearing in mind that kind of health warning at the beginning of the talk about over-medicalizing things, we'll not dwell on this too much, but it just gives an idea about the kind of things that the clinician or the clinical team should be thinking about in patients who've got this combination, because there are specific tests that you need to do. And for some of these conditions, there's then specific treatment that you might not otherwise think about doing. Okay, so ADHD only gets a single slide, partly because a lot of the messages are the same as what I've just said for autism. So again, the sort of overall prevalence, I think most people quote it as like 4 or 5% of children, and mainly is the combined type. A smaller number have the inattentive type. If you look at children with epilepsy, that figure rises to 30%. So 1 in 3 children with epilepsy will also have ADHD, and the inattentive type now becomes much more common. And again, this is important for families and schools to know, because again, a bit like girls with autism, children with epilepsy and autism might not present in the usual way that somebody, a layperson, might expect them to look. And certainly at the time of diagnosis, between 12 and 40% of children and young people will have ADHD that might not have been labeled or diagnosed as such, but they will already be having those kind of symptoms. So it's definitely an important thing to be thinking about and asking about. There are certain types of epilepsy where the association is particularly strong, and that's both in generalized epilepsy. So one good example is childhood absence epilepsy, as well as focal epilepsy. So SELECT is an acronym. So it used to be called Rolandic epilepsy, which was a lot easier to say. FLE is frontal lobe epilepsy. Again, like with autism, there's a strong association with sleep and learning difficulties. Not just that, again, that association, but one being bad affects the other. There's also association and problems with polytherapy. So if you're having to take several epilepsy medications for your seizures, that potentially has an impact on your ADHD problems. It's very clear now that there's no contraindication to going on stimulant treatment for ADHD. So that was something that I got asked from time to time by my community colleagues. We think this is ADHD. We know you're seeing it for epilepsy. We wanted to wait and not start Ritalin yet because of X, Y, Z. And I think the evidence is very clear now that there's no reason to not get on and treat the ADHD. Of course, that implies that you have a supply of the medication to give them, which obviously has been an issue recently. This last box came from a review done by ILA, so the International League Against Epilepsy, looking at this issue specifically and recommending that once children turn 6, which is around the time that they often get referred for an ADHD assessment, in the epilepsy clinic, we should be thinking about asking about and screening for ADHD because of this high percentage. And they said that the SDQ, so the Strengths and Difficulties Questionnaire, was a suitable tool because it's quick and easy to do and gives reliable results. And so we're waiting on, hopefully in the next year, this being available electronically, probably first as a pilot in the York area, but then hopefully then after that more broadly to make it easier and quicker for us to do that. And that, of course, links into the National Bundle of Care, which the NHS England released in autumn of last year, which talks about the importance of screening for mental health, learning behaviour type problems. Okay. So this next bit is just about staring or vacant episodes in children. So on the left is a small audit that I did of referrals from my community colleagues. A lot of the time they were asking whether this child who's having vacant episodes had epilepsy or not. You can see here that the big green bit of the pie chart is the ones that did not have epilepsy. So actually, about all the referrals, there was only one that was definite and one that was possible. And then the pie chart on the right was, well, if they didn't have epilepsy, what did they have? So you can see just a wide range of different weird stuff that children are known to do. On the right here is a different audit that I did last year, which looked at first EEGs done on children who presented in the 3 months prior to the pandemic kicking off at the beginning of 2020, to see how many EEGs were we doing and what was our hit rate, if you like, how good were we at picking up abnormal ones. And as you might expect, we weren't that great. And you can see here, the blue bars are for the EEGs done for vacant episodes. So you can see it was the only reason why the community guys did them, but it was a common reason for the rest of us to do them as well. And most of the time, these came back normal. So we know it's a common problem. I don't even say it's a problem, it's just a common phenomenon in children that they will stare or appear vacant or less responsive. And actually, although it's a common reason for referral into clinic, it's rarely epileptic. So one paper I found described these as non-epileptic episodes. And so they gave them this acronym of NE. And so this is just some of the reasons why you might go vacant and it not be an epileptic attack. So preoccupation, daydreaming, if you've got learning difficulties, if you've got inattention, so again, linking back to ADHD, if you've got sleep problems and you're just knackered, if you're having dissociative seizures, migraine, mood disorder, there's lots of different reasons why a child can be not fully with it. Down here at the bottom was a review of the different reasons why children can stare, broken down by different age groups. So you can see that across the age group for childhood, between 80 and 90% of the children did not have epilepsy. They had something else. And this top sort of bar chart just shows the age at which these different other weird things can present and then go away, which is why it's so important that you get in to see the right person, because it's not just about thinking about and diagnosing epilepsy, it's knowing about all this other weird stuff as well and trying to be able to sort of tease it apart. So this is a summary of various different papers that I found. These were the main clues from the history that helped to differentiate whether a vacant episode was epileptic or not. So the key ones that I'll just pick out are if the vacant episode happened while the person was actively doing something like talking or eating or playing with a toy, and the episode came along and interrupted them and stopped them, and they then had a complete lack of awareness for a short period of time, and then came back around and carried on as if nothing had happened, that's highly likely to be an epileptic event. With non-epileptic vacant attacks, they can still be unresponsive to voice if they're really deep down inside themselves or really just thinking about something else, but they should still respond to touch. The other thing that was helpful is who initially saw and flagged up the concern. So with epileptic attacks, it was obviously the family. Often with non-epileptic attacks, it was a teacher or other health professional. So I'll sometimes get a referral from like an ENT colleague or from physio who just happened to notice a child that they were seeing staring, but it hadn't been noticed by the family. So that's a kind of a clue that it probably isn't epilepsy. And then these things are kind of more obviously seen with epilepsy, although nothing is guaranteed, nothing is 100%. So any or all of these can also be seen with non-epileptic attacks. So you have to take everything with a pinch of salt, and it's about, again, getting that history and building up all these different little clues so that you can try and come down on one side of the fence or another. One interesting one to sort of think about is after the attack, if the person is confused or irritable, that's more likely to be epilepsy. If they're just a bit tired, that's more likely to not be epilepsy. So dissociative seizures as a specific reason why you can go blank and vacant. So they've got a variety of names depending on where you look. So they can be called paroxysmal non-epileptic seizures, non-epileptic attack disorder. They used to be called pseudo-seizures, but that terminology really shouldn't be used now. The idea being that you have a dissociation or a stepping back from reality. It's a subconscious thing and is often linked to or triggered by heightened emotions, anxiety, that kind of thing. So these sort of tables just show in the bottom one some clues that allow you to distinguish an epileptic seizure from a dissociative one, and in the top table looking at dissociative seizures and the difference between teenagers and younger children. Quite a common issue that we find is that a person will have quite a prolonged attack, particularly at school, and the school then get worried and call an ambulance and they get taken to A&E, by which point they've come around and they spend hours in A&E and then go home and then no further forward. So actually the longer an attack goes on, particularly if it's a convulsive attack, but they come around and there's no real postictal period, that's highly unlikely to be epileptic. But again, you need to know about these clues to kind of pick it up, which is why, again, you need to get in to see the right person. Dissociative seizures, so they can occur in someone who says they're not stressed. So sometimes it can just be that the person doesn't recognize what they're feeling as stress. It can be associated with certain personality types. It can obviously be associated with an obvious single trauma. but more commonly, there's been a bit of stuff just grumbling away in the background for months or sometimes years. Thankfully, abuse, so child abuse, particularly sexual abuse, is much less commonly found in children with dissociative seizures compared to adults. So often it's this other stuff. So difficulties or problems either at home or at school. So we're getting near the end. So just specifically staring and ADHD. So these things on the right, again, from the history, help to decide which side of the fence you're on. So if the child struggles to complete their homework, doesn't remain on task, those, if the parent answers to both of those, then that's the sensitivity and specificity. So you can see that that's better than doing an EEG, just those two questions by themselves. As again, I've said in the previous slide, it usually doesn't interrupt play, is noted by somebody else. And if you put your hand on them and talk to them, they will come round. Staring and autism, the things that are more likely to suggest an epileptic event is actually short duration, as I said before, getting more common over time, the postictal irritability, crying or confusion, automatism, so kind of non-purposeful movements that can occur during a seizure, which can be something simple like sort of lip smacking or chewing, sort of fumbling at your buttons, or can involve sort of walking around, which the patient isn't in control of and usually doesn't remember afterwards. And again, not responding to external stimuli.